Matt has been a longtime teacher in our 3-day EKG challenge, but he recently put together his own advanced EKG masterclass. And this is kind of a sampler from that so that you can see his style. His graphics are legendary, and really you'll get to see in just a minute. So Matt, whenever you're ready, take it away.
Alrighty. Well, hello everyone. My name is Matt Holden. Jennifer was extra nice, but yes, I was originally a paramedic for about 5 or 6 years, and now I'm in PA school. And I love talking about EKGs and just trying to make them super simple. So let me see if I can share my screen. So is everyone able to see that?
Yes, looks great.
Perfect. Let me see if I can pull up the chat, move it over here. And so I have multiple monitors here, so I'm trying to watch both at the same time while doing the advanced EKG class. But in this, Jen was doing a couple giveaways with some EKG badges, and I went through all the comments and I saw a couple topics I wanted to cover as they seem to be the most popular. First off, we're going to be talking about our STEMI mimics, and there's a decent amount of them. We're going to obviously talk about hyperkalemia. That's one of the greatest imitators out there. It's also one of my most favorite things to see. You also have left bundle branch block morphologies or V-pace rhythms. You have early repole, LVH, pericarditis, hypothermia, low Brugada, and those are going to be the ones that we're going to talk about. And I will say at the very end, I will give a little bit of Wolf-Parkinson White because a couple people requested to know a little bit more about that. So without further ado, we're going to talk a little bit about the STEMI criteria. If you're a long follower of Jen's, you kind of know a little bit about this, but essentially you're looking for about 1 millimeter of elevation in 2 contiguous leads. Thank you, Michelle, for talking a little bit about the leads in the last lecture. You have your lateral leads, which is going to be 1 AVL, V5, V6, and their best friends and the most reciprocal to them are going to be in your fear leads, which is 2, 3 AVF. You can see all the different types of leads there and the reciprocal changes. For men, just because medicine just has to throw a curveball into almost everything, you have to know a little bit more criteria. If you have a man who's less than 40 years old, you need to have the elevation needs to be greater than or equal to 2.5 millimeters in V2 and V3. If they're greater than 40, it needs to be greater than 2 millimeters to call it a STEMI. In women, greater than 1.5 millimeters in V2 and V3. And then your posterior wall MIs, you're going to have ST depression in like your V1 through V4, but it's not going to be mostly seen in V1. It'll be more focused on V2, V3. But if you do posterior leads such as V7, V8, V9, where you move some of the precordial leads to the back, you'll need to only have a little bit of elevation of greater than 0.5 millimeters to call it a STEMI. And that's just the basic STEMI criteria. So another big thing I was told to incorporate is your coronary arteries in the basic EKG sites. So your aorta is kind of where AVR kind of looks at. And as Michelle was talking about, it's all these pictures and where all the leads are looking at. So if I wanted to look at where my LAD is, it's going to be focused on V1 through V4. If I'm worried about my circumflex, you're going to see elevation in 1 AVL, V5, and V6. And then my right coronary artery is going to be 2, 3 AVF. So I'll have elevation in those 3 leads, and then I'll probably have some depression in 1 in AVL. So hyperkalemia, one of my most favorite things to ever talk about. If anyone knows Dr. Alma-Mathieu, he calls this the great imitator. It mimics everything from ventricular tachycardia to, as you'll see, to some STEMI stuff, and it can cause heart blocks and cause so many different things. This is thought to be a poison sodium channels or sodium channelopathy. And as you can see, it does cause some ST depression and reciprocal elevation. But one of the big pearls I like to say with hyperkalemia, if you look at it and you say that is wide and bizarre, it is probably hyperkalemia. And this is a great example of this. You see it's over 1 big box wide here. And when you see anything that's over 1 big box wide, the QRS, you need to start thinking of any kind of tox or metabolic problems. But we're here to talk about hyperkalemia mimicking a STEMI. So these ones right here have been ones that have been sent to me when I was a paramedic, being like, hey, is this a STEMI? And I was like, oh no, it's not. Unfortunately, these did have some bad outcomes, but what we'll do is we'll try to learn from this. So when you look at this, and if you've seen any kind of STEM, you'll kind of look at this and be like, something about this doesn't look like the right kind of STEMI that you're used to. You kind of see these little pointed T waves right here, but you will see some depression in 2-3 AVF, some reciprocal elevation in AVL. You'll see AVR and V1 also have elevation. This patient had a potassium, I believe, of 7 to 8. And like I said, they were not given the proper treatments. They were brought to the cath lab, and then they realized, oh no, this is not very, very good. But what about this one? What do you guys see here? So obviously this is hyperkalemia mimicking a STEMI. Where do you guys see your ST elevation and depressions? So you're going to see some in 2-3 AVF. Once again, have those elevations with those red lines right there. Yep, Allison's right, 2-3 AVF. We have a reciprocal changes, and 1 in AVL has some depression in it, along with V2 and V3. But those little yellow circles that I put there are kind of indicative of this. You can see how they're kind of just pointy. Looking V4, V5, V6. It's looking wide. It's looking nice and weird. And you got those really pointy symmetrical T waves. Usually when you have STEMIs, you're going to have more of a wider base T wave, and it's not going to be that nice and pointy thing. I like to think of this, and I was always taught as, you don't want to ever sit on these T waves because they're going to hurt your butt. They're nice and pointy, and they hurt. So this is going to be hyperkalemia, once again mimicking a STEMI. Yep, KJ, pointed with your booty. Now, one of the things I love to also talk about is the modified Scarbosa criteria. This is something that probably gave me a little bit of high blood pressure when I was in paramedic school. But there was some refinements to this. So at first, you're going to notice if this is with any kind of left bundle branch block or a V pace rhythm. You can even see this in some of your left bundle branch block morphology PVCs as well. If you follow Dr. Stephen Smith, he's got a great blog. And that's where I got my inspiration for a lot of these. But he is the person who helped modify this. So it's called the Smith-Scarbosa criteria or the modified Scarbosa criteria. So you have 3 different things here. You have 1, concordant elevation, which can be in any lead. Concordant elevation is fancy terms for my QRS and my T wave are going in the same direction. Lisa, my husband is a paramedic and he caught that one. Heck yeah, that's awesome. Concordant elevation, QRS is up, my T wave is up. And that's what it means by concordant. And you also have to look for concordant depression. My QRS over here is going to be going down, and there's some ST depression. But this is where it kind of changed. So back in the day, it used to be any kind of ST elevation over 5 millimeters was really, really bad. And that was considered a STEMI at that point. Dr. Stephen Smith came in and realized it's all about proportionality. So proportionality is basically you take your ST elevation, which is right here, which is 5 millimeters on this imaginary thing I drew here, and you divide that by your S wave, which is going to be 17 millimeters here. Now, if it is greater than or equal to 0.25, then it's going to be considered a STEMI. So 5 divided by 17 is 0.29, and you should be really worried about some kind of STEMI associated with this patient. Now, another big thing I was asked about is left versus right bundle branch block. My wife is a nurse and she always had difficulties with this as well. So I like to make things that are complex or difficult to understand and try to just make them simple. So imagine yourself driving, right? You're in the driver's seat. You're like, I want to get some Taco Bell, or I want to go to this really nice restaurant, and it's on the left-hand side of the road, right? How would I turn left? Which way would I have to turn my turn signal? Would it be up or down? It'd be down. So if I want to turn left into the coffee shop, that's how I'm going to turn in there. So if it's wide and down in V1, you're most likely dealing with a left bundle branch block. Now, a right bundle branch block. If I want to turn right into a McDonald's, I'm going to have to put my turn signal up. So if it is wide and up in V1, it's going to most likely be a right bundle branch block. Alyssa, yeah. So this is the down and dirty version. That's the way I like to teach it. You usually look at V1 and V6. for a bunch of different criteria. But that's why I say you're most likely going to be dealing with something if you're looking V1. So McDonald's is on the right. Yes. So V1, like I said, if it's wide and up, you're probably dealing with the right bundle branch block. If it's wide and down, you're probably going to deal with a left bundle branch block. And that's just a really easy way for a lot of students to try to grasp this. So here's an example of your left bundle branch block EKG. So this, you're going to see obviously ST elevation in V1, V2, V3, and you have your depression in V5, V6, lead and lead 2, and you also have a low in AVL. But if you look in lead V1 right here, I'm going to have a little blip there, a little blip there, but it's going to be wide and down in V1. My QRS is down. So that makes me think, okay, left bundle branch block morphology here. And as I was talking about before, it's about proportionality. So when you have left bundle branch blocks, it's kind of normal to have something called appropriate discordance, where I'm allowed to have a certain amount of ST elevation, as long as it's not too much in comparison to how deep my QRS is. It's all about proportionality. If I can fit a QRS complex into a T wave, then that means that you're really looking at some kind of ischemic event. So here you can see I have my QRS going up in lead 2. So appropriate discordance means I'm allowed to have some ST depression here in lead 2 as well. In V1, my QRS is going down, which means it's okay if my T wave is going up and I have a little bit of elevation. If you're really ever worried about something and you're worried about the proportionality of something, you always got to remember the Smith-Scarbosa criteria. Count your elevation here and then divide it by your S wave in millimeters. And that should give you a number. And if it's greater than 0.25, then you should be kind of concerned. I've only probably seen 2 left bundle branch block morphologies that met the Smith-Scarbosa criteria. So it's not super common, but it's just something to look out for. Now your V pacer things, you're going to also notice this. You're going to have these little spikes here before the QRS, and you can also see them right before the P wave as well. This is going to be your AV pacer. So one's firing off a P wave and one fires off a QRS or the ventricles. So with these, you're going to have usually, because nothing is really ever an absolute. If it's wide, it's usually going to give you kind of a left bundle branch block morphology. You can see here my QRS is up, my T wave is down, and I'm going to have, if my QRS is down, I'm usually going to have a little ST elevation. There in Dr. ECG's blog, Dr. Smith's ECG blog, he was able to determine several types of STEMIs, even in patients with ventricularly paced rhythms. So just wanted to bring that up there. Now, early repolarization. Yes, Allison, yes. So the Smith-Scarbosa criteria can even be seen in PVCs as well. I was reading one of his blogs. It was probably 7 years at this point, and he was able to diagnose a STEMI. You can get into like an occlusion myocardial infarction or a subtle STEMI, and that patient was having one, and the only real elevation he could find was going to be a random PVC he did the Smith-Scarbosa criteria on it, and met the criteria, and the patient evolved into a full-blown STEMI. But to be honest, I haven't seen it in a PVC. So early repolarization is something that I think almost every one of us who's looked at a 12 lead has probably seen. I remember when I was a brand new medic and I saw this and I had a little panic in me when I very first saw these. So yeah, I get duped a lot. So essentially you're going to look for widespread ST elevation, and the textbook or classic thing you're looking for is your fish hook appearance on your J point. You can see a little bit of notching, but one thing you'll notice is something called normal R wave progression, where essentially is V1 is going to have a little baby R wave right here, and it's going to get bigger and bigger and bigger until it's almost completely upright in V6. And that's essentially the down and dirty way of saying normal R wave progression. If it goes from really small here to big here to then smaller again, then it has poor R wave progression. You got to start looking out for some kind of ischemic event. So in this, we're going to have some ST elevation. And here you can see in lead 2, there's that little notch right there. And this is kind of normal-ish. I think I did see a couple years ago, and I'm sure Jennifer could correct me on this. They're thinking that it's no longer super benign, and that if some patients who are older, over 50, 60, it might be more of a problem than calling it benign. So they're calling it more early repull. Missy, yes. So right here in lead 2, you're going to see that little notch right here. This is the little fish hook right here. Um, and here you can see it in lead 2 right here when it's not blown up. So this is it right here. And you can see a little bit of elevation. It does trick up a lot of people though. Another one is going to be LVH, or left ventricular hypertrophy. So LVH, there's a lot of different criteria out there. You can do your Sokolov line criteria where you start adding stuff together, and then you add all them up to eventually see if it's over 35. I'm very simplistic. I hate counting. I don't like using calculators. So my down and dirty way of doing LVH is essentially if you look at something and my QRS complexes are all touching, like they are here, you can see how all the QRS complexes are running into each other. I like to call that high voltage. Another high voltage thing that you can find is one of Jen's favorite topics, and that's going to be hokum, which I'm sure she might talk about at some point. But this is high voltage. And you can also get something that is kind of in the literature. It's what I was always taught as the strain pattern. Essentially, it's these these T-wave inversions right here. This inverted T-wave right here, and you can see it right here. This is what people used to call the strain pattern. Now, pericarditis is something that I've only seen a couple of times, but I always find it super, super interesting. So some common findings you can get is like your patient with some crushing chest pain or pleuritic chest pain when they're laying flat, but when they sit forward, they feel a little bit better. Has anyone ever seen any kind of pericarditis before in their life? Allison, yes. Yeah, so it's yes, okay. So we got a bunch of people who've seen pericarditis. A lot of this can be used due to IV drug abuse, or even if they had a recent dental repair done, they've noticed that a lot of patients get pericarditis with that. There's a lot of different reasons you can get pericarditis. Some of the EKG findings you will find is widespread ST elevation. We also find some a little bit of PR depression, some downsloping TP segments, which we'll show later is called your Spottic sign. And there really shouldn't be any kind of depression, except in Michelle's favorite lead, AVR. And you can also have a little bit, you can also have it in V1. But if I start seeing depression in lead 3 or something like that, then I'm like, okay, it's not pericarditis. So, endocarditis as well. Yes, Missy. It's really difficult to kind of just look at some kind of EKG. I was always taught to diagnose endocarditis, pericarditis at your own peril. So just make sure that you're not just throwing pericarditis around like all the time. Um, so here is one patient that I had a couple years ago, back when I was a lot younger. So first off, do we have widespread ST elevation? Yeah, this patient's either having the world's largest heart attack or it's pericarditis. So we do have that. Now, is there any PR depression? We do have it a little bit right there, the P wave, and it sags a little bit right here. The PR, it's dropped down a little bit. That's not seen in all of them. Is there any reciprocal depression? No, except for AVR. That's okay. And when you start thinking about leads, AVR is thought to be the reciprocal of the majority of your leads or a lot of your left facing leads. So if you have a lot of ST elevation everywhere, you should have depression in AVR. And you'll notice that with a lot of your ventricular or really fast rhythms, like your SVT, you might have some ST elevation throughout the rest of the 12 lead, but AVR, or depression in those leads, and AVR will be positive. Now, finally, Spottic sign. This is something that's really, really fun. If I zoom in here, you can actually see the T to the P is actually having this downsloping appearance, and that's called your Spottic sign. And I forgot who it was asking me about the notching. You can actually see a little bit notching that you can find in early repolarization right here as well in lead 2. This isn't like always found in pericarditis, but it's just a nice little finding I found right here. Now, hypothermia. So you're going to have something called an Osborne wave. And this is essentially the J point is more pronounced and it's elevated. I don't remember exactly what this patient's core temperature was, but it was pretty cold. I was sent this. So Can anyone see where the J point or Osborne waves are on this 12 lead? Hey, Mustafa, how you doing, man? Allison, yep, V4, V5, and V6. You can see a little bit here in lead 2. And then I have a question for everyone. What's all this on the very bottom strip? All right, everyone's seeing it. What's all that squiggling down here? Yep, shivering, exactly. So these patients are usually at first they're gonna be shivering. If they're no longer shivering, that means they're really, really, really cold. But yes, these are gonna be this is a hypothermia patient. It's quote unquote mimicking a STEMI. You guys nailed it. Another one, this is another hypothermia patient. But this one just has more pronounced J waves right here, but it's really not showing massive elevation like it was in the other one. Now, Brugada syndrome. Now, Brugada is a very interesting thing. Is it's like it's several conferences that like to change what's taught and the different types and stuff, but essentially it's an autosomal dominant gene mutation of the SCN5A. You eventually lose your sodium channel function. Now, one thing I've always like to teach is Brugada's sign is when you have the EKG finding, but you don't have like all the different types of symptoms or familial history associated with it. Brugada syndrome is the EKG sign with the symptoms. And there are quote unquote three types. Some places like to teach three types, but there is a disclaimer for a reason. Some people have combined type 2 and type 3 together. Some people have just got rid of type 3 altogether. Regardless, that doesn't matter. We only care about type 1. So in type 1, you're going to have a pseudo right bundle branch block. You're going to have ST elevation in V1 through V3, but it's mostly going to be prominent in V1 through V2. And you're going to have something called terminal T wave inversions. So here is So right off the rip, so here's this patient. They called with a fever, and I don't remember why I did a 12 lead on them, but regardless. So in this patient, we can see a pseudo right bundle branch block. So let's zoom in on V1. We have an RSR prime, and you can see this coved ST elevation right here, right? This coved ST elevation. Jen and I like to talk about this as ski slopes. These are your ski slopes, and that's how you can decide a Brugada. Now, terminal T wave inversion is some fancy, fancy term because medicine likes to use these fancy terms, and all it means is at the very end, the T wave is inverted. The terminal just means the very end part of the T wave is inverted. It's just down right here. So I'm confused. The QRS is down in V1. So this is where I say it's the not everything is an absolute. You're having like an RSR prime, then you're gonna have technically a right bundle branch block or a suit. That's why it's a pseudo right bundle branch block morphology. It does get, unfortunately, the further in the weeds you get, the more confusing it gets. But here's WPW. I know I have a couple minutes left. So Wolf Parkinson White. So this is a congenital heart defect, and it's called a pre-excitation syndrome. You got a bypass tract or an accessory pathway, which is going to be important for all of your exams who in PA school. It's called the bundle of Kent. I just took a cardiology exam, and that was really one of the questions was what's the bundle of Kent and associated with? So some of the findings you're going to get is a short PR interval, which is less than 120 milliseconds, something called a delta wave, which is a slurring essentially from the P to the QRS right here, just outward slurring. And you're going to have a little bit of a widened QRS because of that slur. So here's your typical WPW EKG. So here you can find in lead 1, you can see this little bob out here, and you can even find it inverted right here. There's a lot of different ways that people like to say like, oh, you can get like your left and right sided tracks, and there's a lot of, that's more of like an EP issue. The big things I want to really preface is a short PR interval. You can see this P wave right here, slammed right into the QRS, and you can see this upslurring right here. And always look at all of your leads because they don't show up all the time in all your leads. Sometimes they're only found in one. So one of the big ones you can look for that's inverted delta wave in V1. Now, here's something when I was doing my rotations, in paramedic school, they showed me this 12 lead and I kept it for a long, long time. And I was like, oh, this is a really interesting, cool 12 lead. They called it, what do you think that these people called this? Does anyone know what they call this initially? Torsades. Yes, they call this torsades. It's not good. So this is actually AFib with pre-excitation. So first off, it's going to be a wide complex tachycardia, and you can see the QRS morphologies are wide. It's irregular. When you look like over here, it looks like it's kind of regular, but look in all your leads, you can see how irregular it is. From my R to R is all different varying lengths, right? Now, another big thing to look for with this is you're changing QRS morphologies and sizes. You can see some of these QRS morphologies all look a little different, right? And now another key thing to look for, your ventricular rate. If you learned about the big box method, is my down and dirty way of learning any kind of rates, is you look at a QRS on one line and you look at the other one, and you can see rates are nearing 300 beats per minute. The only thing that can do that is going to be AFib with Wolff Parkinson White. And this is the post-conversion 12 lead. Now, I do have a quick question. Does anyone know what medications you should not give AFib with Wolff Parkinson White? AV blockers, yes. Beta blockers, yeah. Anything that's going to essentially, so you got to think AFib is essentially 400 to 600 impulses in your atria, right? And the power of the AV node is like a gatekeeper. It squashes a lot of those signals. And so it only gets you, 300 beats per minute at times. So it's squashing out about half to, three-quarters of all the impulses, right? So if I go and I block off my AV node, my gatekeeper, and says, nope, don't worry about it, all those 600 impulses are going to go down to the bundle of Kent. And then the bundle of Kent will freely accept them. And then you're going to go into the very lethal rhythm of ventricular flutter for about 3 seconds and then into VFib, which is not very good. But this is the post-conversion 12 lead. You can see those delta waves right there, which was not picked up by me for several years until I finally learning about all of them. Kent is a menace, yes. And I am down the last 4 minutes. So Jen, if anyone has any questions, yeah, it looks like Facebook and not Instagram, but Zoom got really you after you point them out, you can't unsee them exactly. Does anyone have any big questions?
Take advantage of getting your advanced EKG questions by the master.
I know I kind of blew through a lot of different topics, but I wanted to cover a lot. It's a lot easier when you're able to break down because STEMI mimics alone can take about 30 minutes really going through a lot of stuff. Equivalence is another big topic that can go take another 30 minutes to an hour for in really diving into each one of them. That fib one, wow, would be helpful to see next to torsades. I can definitely see if I can find one. Drugs that exacerbate Brugada syndrome, WPW. Yeah, lot tell us more about this EKG class. So essentially, Jen and I have I'm assuming everyone wants me to kind of stop sharing real quick. So Jen and I have actually worked together. I made it a whole EKG class, and that was a brief snippets of different parts of them that I incorporated all into one. But we have an EKG workbook right here. I should add her website, which is conqueringcardiology.com. It's a great workbook that myself, Jen, and Ruben all put together. It was a beautiful masterpiece, but it helps essentially break down everything and you work along with the EKG class. And another big thing is I know people really love these various STEMI cards, and we do sell them. It's on scopemed.com. Unfortunately, it's just for the United States of America because I can't figure out how to ship internationally just yet. But they do run out pretty quickly, and I know Jen does have a lot that she's she's doing giveaways and stuff like that, and it seems like people really like them so far. Any last minute questions?
Allison says she's collecting them.
Allison's collecting them. Michelle, you gave them to your kids for Christmas presents. That's awesome.
So I think, again, Matt has this advanced course you can purchase. It's on our website. It comes with a badge and comes with his workbook that, like I said, Ruben and him just created like this week. So even if you've bought the course before, you'll be getting access to that workbook that goes along with the content. And you can always reach out to Matt, on his Instagram, Scope Education. And he also does many lectures for us in our 3 and 30-day EKG challenges. So we're really grateful to you, Matt, for all of your contributions as usual. And we're going to take another break. Michelle is going to tell us the minutes, and then we'll be back to do killer EKGs. Also, yes, if you are going to purchase the 30-day, you are getting an EKG badge of Matt's. If you're not and you want his badge, reach out to him and he can, like he said, hook you up with the connection for that. So Michelle, what's our break time going to be?
Oh, looks like it has to be pretty quick. How about a 3-minute, and I'll do 23 seconds. How's that?
Okay, we'll see you back.
You guys are awesome. Thank you.